This is the 1 Million Lives podcast by Laerdal. Listen to healthcare professionals, healthcare educators, and survivors share their best practices and what they've learned from these experiences. At Laerdal, it's our goal to help save 1 million more lives every year by 2030. One life at a time.
Hi again. Welcome to another episode of the 1 Million Lives podcast. This time around, we have a very special guest. He's local from the city of Stavanger, where Laerdal is situated, but he's achieved some remarkable results, and I'm really keen to hear more about this. To frame this discussion, I would like to say that this is one of the biggest causes of death around the world. This is about stroke. And the likelihood that yourself or someone in your family will suffer a stroke during your lifetime is very high. And we're really keen to understand what is being done to provide best possible care for those who suffer a stroke. So with us today, we are honored to have with us Dr. Martin Kurz, professor also. Welcome, Martin.
Thanks a lot. Exciting to be with you.
Thanks. Maybe you want to introduce yourself to the audience, your background and what you do.
No, thanks for the possibility. My name is Martin Kurz, as you introduced me already. I'm a stroke physician from Germany, working now in Stavanger University Hospital for the last 20 years with stroke most of the time, actually. And I'm professor at the university in Bergen and leader of the National Stroke Association in Norway, and really excited by the possibilities of treating stroke and this devastating condition, as you lined out in the introduction, that came up in the last couple of years.
I think that's a good actually starting point. Could you, for those who do not know the intimate details of stroke, could you say a little bit about what kind of a disease is it and how is it experienced for those who suffer a stroke?
Yeah. It's kind of, I think stroke changed in the perception of the people in the last couple of years, like being a disease of the old ones, being not treatable, to being a high acute medicine condition, being one of the most important to come quickly to hospital, to come to treatment. And stroke occurs actually when something blocks the blood supply to the brain. And if the blood supply is blocked, it's an ischemic stroke, or it can be a blood vessel in the brain that bursts as a brain bleed or intracerebral hemorrhage. In either case, the consequences are the same of both parts. The brain does not get enough oxygen and becomes damaged as brain cells die, actually, and function of loss is the consequence of this. To work properly, brain cells in our brain needs oxygen. So people experience a loss of function depending on which parts of the brain is damaged. It could be a loss of speech, paresis, loss of mental function. It depends on, as I told you, which part is damaged. And this is scary for the people, of course, because they can't perform their task anymore. They can't lift their limbs. They can't walk. They may be dizzy. They may lose the ability to speak, depending on which parts are affected.
Scary indeed. So if we take sort of the big picture, how big of a problem is this globally today?
Oh, I just looked up the numbers in the global fact sheet of the global stroke global world organization. Around the world, there are 12 million new strokes per year, meaning that there's one new stroke every 3 seconds. And this has a tremendous impact on the people. There are 101 million people worldwide that are living with a stroke aftermath. And as you told, a lot of you people listening to the podcast or your family will have a stroke. 1 in 4 people will have a stroke in their lifetime perspective. And it's not not a disease of the old anymore. 63% of the strokes happen in people being younger than 70. So it's really as well. I think it's 28% being in the 20 to 40 age people. So a lot of young people get strokes, and of course there are a lot of economic figures as well attached to that. So it's a very costly disease.
I can imagine. And it's by no means binary. I mean, quite a few people survive and have to live with the aftermath of a stroke, I guess. And yeah, I have a close friend who suffered a stroke, and his working ability went down, of course, with all the consequences that has for his family, himself, and society at large.
I think it's not just that people are not able to work anymore. I think the consequences are much broader than dropping out of the working community, with the economic loss for society, of course. But people are changed. There's a tremendous problem for the families. A lot of divorces happen in families living with stroke survivors. So it's a huge problem for society, not just economically.
So you said something earlier that intrigued me. You said that there's been a change in perception of treating stroke from something, like you said, that happens to elderly people, and the outcomes is or were probably not easy to do something about. And then you said it's now sort of transitioned into being a acute care discipline. Could you say something more about that?
Yes, it's quite interesting for me, especially working with the disease as a stroke neurologist, to follow the journey the disease has taken from when we started quite early to increase the public awareness of stroke. We met people asking why is it important and you can't treat it anymore. It was as well in hospital. The other departments didn't see the necessity to increase awareness or increase workload internal in hospital on that disease, because it would take resources from other diseases. And then kind of the perception of the disease changed, and they understand that it's so important to get people quickly to treatment, that they're quickly in hospital as well. With hospital resources, if you get people quickly treated, they can get actually healthy. They don't need any more resources in the hospital, or after they have the well-treated stroke, after the stroke is well-treated, they can completely be normal afterwards again, so they can participate in society, don't need any more resources. So it's highly effective treatment, and I think the perception has changed both in society and in hospital.
But you guys and your team here in Stavanger, you have taken it a step further. You made this into an initiative whereby you wanted to improve the quality of the treatment. And in a slightly populistic way, I can tell the audience that Martin and his team has what it seems to be the best published results globally on what is called the door-to-needle time. Could you say what is that process, and why is it so important that it happens quickly?
Yep, as I told in the introduction, that if the brain doesn't get oxygen, its immediate consequence is that the brain function is shutting down. But this does not mean that brain cells are dead immediately. There is some minutes and hours, depending on the individual circulation in the brain, how long you can successfully treat patients. So it's of utmost importance to get the patients very quickly into the hospital and get them treated efficiently in the start of a stroke, in the first minutes, hours. We have a study showing that if you manage to treat patients within the first hour of the stroke happens, they get healthy in median. It's all about time. Get them quickly into hospital, get them treated efficiently. They can leave without an aftermath.
So what are the current guidelines here? I mean, what are we striving to achieve? Are there any recommended sort of time slots on treating stroke?
Yes, it is. But I think it's not the guidelines we're talking about. I think it's the individual performance in every case to get the patient as early in hospital. And I think if you set a certain timeline, you say on the same time, it's not important to get the patient in quickly afterwards because the time is limited. And we have evidence now that you, by advanced imaging, can detect patients as well after 16 or 24 hours that can be successfully treated with acute treatment. So it's all about getting the patient as quickly as possible into the hospital and then treat them if possible. The patients to treat, you have to detect by advanced imaging then.
But the work you and your team did, it was truly a healthcare quality improvement initiative. And your aim was, as I've read it in your paper, was to reduce the door-to-needle time because you expected that could have a measurable positive outcome on patient outcomes. So what was the project about? How did you go about sort of running the project, and what were the outcomes from it?
Yeah, thanks for the question. I think we were very challenged by the Helsinki group in 2012 publishing a paper that they did thrombolysis with a door-to-needle time below 20 minutes, and we were not there actually. We had more than half an hour, and what was more stunning, it was not the median time, but in some patients we needed more than 1 hour to administer the medicine and get them through the system. So we're kind of challenged by the results of the Helsinki group, and the aim when we started the project was just to get an equal number, or the aim that we set to beat the Helsinki group in times of minutes, that we need less minutes to administer that. And the consequences of the minute spirit, we weren't sure about that. We were very interested in ruling out the consequences of the project. It was meant as a quality improvement project, but in the first run, just a saving of minutes-based approach. Then we of course, later on in the run of the project, we saw a couple of different aspects and consequences being much more worthy and notefully than the minute spared.
So you're quite competitive, are you?
Kind of a positive competition. Yes,
yes.
I am.
Yes.
Try and like to find out why other hospitals perform better than our hospital and try to learn.
So tell us about the inner works of the project, because as I understand it, you deployed many things. You aimed to use simulation for this. You worked on the procedures, and all of these things sort of came together. What did it actually look like in practical life?
And in practical life, it was the first run we had to go through the protocols and tried to improve the protocols, take out all unnecessary steps, understand why we do what, not just do things because they were done earlier, but they needed to have impact in patient treatment or decision we had to take. And then we tried to put all the things that were in the protocol in the right time point in the patient treatment. We tried to move things from the hospital to the pre-hospital scene, that we could save time, just the pre-hospital transport not being transport, but diagnostic and patient preparation. And after we had then adjusted the protocol, we did so quite often until we ended up with a proper protocol working for our hospital at least, and for the pre-hospital guys as well. Then we started simulation training and training the protocol. but it demands as well, if you just change protocols and you tell people to follow the new protocol, it's not followed. You need ownership in the different departments participating in the treatment of these patients. You have got to form a correlation that they're part of the team working on the simulation project or the quality improvement project as it is, and you have a good communication that you feel when people are dubbing off and not keeping the pace, or if they don't feel any ownership to the project, you have to implement the ownership. So it's kind of, you're a team together with all the people participating in the project, and this is of utmost importance.
So it sounded to me like you primarily use simulation to implement the best possible protocol you could develop for this local hospital. Is that correct?
I think simulation has different aims in a quality improvement project and medicine in general. We learned that as well in the COVID time, that we changed the protocol. Look, you have then a stroke, neurologist, highly infectious disease, and people are scared about that, and neurologists don't want to come close to people with a respiratory infection because they're scared of infection themselves. So we had to train and adapt the protocol by simulation training in COVID times until we found the right protocol for the patients and the doctors to learn the doctors how to treat infectious disease, that they're not just neurologists, but infectious doctors as well, that they can protect themselves, that they can protect the team from being infected themselves, and to treat the patient efficiently at the same time. And there we use simulation training to adapt and change the protocols a couple of times until we found the right protocol. But then after we found the protocol and made the changes, then we use, of course, simulation training to do every team member familiar to the protocol, to implement the protocol. And I think their simulation training is highly efficient as well.
This is a 1 Million Lives podcast by Laerdal Medical.
You mentioned the team members. To what degree were the employees part of this work, and how was it seen by your colleagues?
I think it's a history there as well. It changed from when we started simulation training. We did so by forming a correlation with the different departments participating in the patient handling, transport, triage, and treatment, and they developed the protocol and the training together with us. And I think this is of utmost extreme importance to get the ownership implemented in the departments, because you use their resources, and if they don't see the sense of urgency, if you don't have that powerful correlation, if you don't have a common vision for change, then you won't succeed to do that. You can't just implement your protocol to other departments and they don't have the ownership. And we did so from the start. And after that, we introduced simulation training, and we had all the way the dialogue with the different departments. Do you feel it's meaningful for your employees? What can we do to make the training useful for your employees? And that changed the perception of the simulation training in the different departments, like from it's just not necessary, it's just filming, it's just actress, from we can use it. It's rather important for us to make the changes, to implement, to form the treatment in the way we want to form it, to get the ownership. So from comments when we started simulation training, like, I don't like to act diseases, I want to treat diseases, I think it's unnecessary. After a while, when we pause simulation training, we get then the questions, when can we restart? It's so important for us.
It's fascinating what you've done here, Martin. And I'm sort of, you also touched upon bringing the pre-hospital services in on this. And so because I could imagine you could focus on a hospital alone, but by bringing in the pre-hospital services, I guess you're sort of expanding to the whole chain of survival. And what did that look like when you trained together with the pre-hospital services?
I think we thought the complete treatment chain all the way, because some of the main changes we did was to delete items of the protocol, to tailor the protocol just to the necessary parts, and we moved parts of the in-hospital procedures to the pre-hospital scene. So we had actually to show and as balancing measures that we don't prolong the patient treatment by prolonging the pre-hospital transport phase of the patients. So we had these measures all the way with us when planning the project. And I think it's as well the pre-hospital transport of the patients. They were the most easy ones to come into a communication about quality improvement for patients, because they were struggling the most with the patients. They had a stroke and didn't know where to deliver and which pace to deliver. So clear guidelines and a clear flow what to do at which time point with the patients, the clear communication was really welcomed by the pre-hospital services.
Yeah, I think your project is rather unique in the fact that you included both the way you have, and actually even went to the extent to move some of the protocol steps to the pre-hospital phase, giving an even earlier intervention, which is, I guess, very important in this kind of setting. Now, all good and well with the improvement project and your initiatives. What have the results been for the patients?
I think the first and most important thing to mention is that we gained the time reduction we wanted to have. So we went below the 20 minutes that were aimed by us. We got a door-to needle time of 13 minutes. That was really stunning,
wow.
kind of for us as well. And this did not cost more minutes in the pre-hospital phase. So we didn't prolong the pre-hospital phase by doing so. So this was really, really cool to see. But it was not just ending there. We were rather surprised that this that we could spare time. The reduction of 17 minutes in time used in hospital had as well a dramatic effect on patient outcome. We saw reduced patient morbidity and mortality, actually. Just have a look. It's a single center study. We did it just in one hospital with not very many patients included over a couple of months. And we did see effects and patient mortality and morbidity. And this was just stunning.
Yeah, and it must be highly motivating to continue working at it.
We did so, and then just you could argue as well, like, it's a half-thorn effect, as that you just have it increased awareness around, and we thought so as well. But we started the project in 2017, and we still have reduced mortality and morbidity, so we can follow it over a long-term perspective. So this,
and
sustainable.
Right, and all of this has been published, of course, so people can look it up, and we will make sure to drop the links to the research papers together with the podcast episode. But sort of, you mentioned this was a single center study, and of course, all that good work you've done. It's tempting to think, we need to disseminate that, we need to spread it. What do you think around on that side of the project? Because I guess any good healthcare quality improvement project should have as an aim, whatever good results you come up with, you disseminate and help others implement. So what are your tactics and strategy there?
Yes, I think it's two ways of dissemination of the project. The first thing I think still to be mentioned is that the gains you have for stroke patients in the ER in the given hospital, performing the quality improvement and training with the simulation training, the gains are not just for stroke, because the people working with the patients work as well with other acute patients in the same setting. So the communication and the team performance you train, that is directly beneficial as well for the teams working with other patients. So we didn't have a look on that, but I wouldn't be surprised that if you look at teams working together in simulation training in stroke, and you just follow the team performance in other diseases, acute diseases of patients coming in, I would not be surprised if you see improvements overall. And we have a gut feeling that this happens, at least with our teams working here in our hospital. And then actually you see that patients with stroke, I think Stavanger is a middle-sized, medium-sized city for Norwegian perspectives. About, I think it's 350,000 people coming to our hospital. We're responsible for the treatment for 350,000 inhabitants zoning to our hospital. And there are a lot of medium-sized or low-volume hospitals treating stroke patients. So the challenge we have with our patients to improve the quality of care is not unique. Other hospitals are struggling with the same challenges in that. And actually, when we presented our results, we got questions as well from other hospitals. Can we join? Isn't that the same? We when we started as well, we had the perspective, kind of a national perspective as well, that we can establish things that can be fruitful and necessary for other hospitals as well. And so we have formed a national collaboration on the simulation training in Norway, and especially two hospitals were very interested in that, in Kristiansand and in Oslo, Ahus Hospital. Both were aimed to start with the neurointervention, the thrombectomy approach of stroke treatment in the setting. And this means that you have, I think the audience might not know what thrombectomy is. There's a big stroke, one of the large vessels being occluded by a clot. And there the intravenous thrombolysis as administered clot dissolvent medicine is not good alone. Very often you don't get reperfused the vessel. Then a team has got to go in with a catheter approach and to just tear out the clot mechanically, or to do it by vacuum pump. There are different methods of doing so with a stent device, pulling the clot out. And this is highly specialized, this treatment. And as I told, the small and medium volume centers, they don't have very much patients. They can train in clinical praxis. So they implemented actually the simulation training, not just the door to needle approach we had in our center, but we expanded the simulation training to the mechanical thrombectomy. We implemented that as well. And they introduced this new method of treating patients guided by simulation training in the national collaboration. And this was it was so positive, this collaboration. It's so interesting to see the positive motivation and the results we could achieve in that collaboration. Both hospitals actually treat patients now on a regular basis, I think for a couple of years now. And I saw last week the latest numbers. They're getting published now. And don't dare saying that. I think both of the hospitals are doing better than we are.
So you're putting back your competitive hat again, I guess.
Yeah.
But that's a true testament, though, to the effectiveness, right? But also a testament, I think, to the fact you mentioned earlier that it always has a local element to it. You always need to localize it to fit with your structure, your setup in your local hospital, I guess.
Yes, but I think a lot of that is generalizable as well, because the I think quality improvement in medicine in general, there are a lot of generalizable items you can pick out, you can use for other diseases as well, you can utilize for further disease as well. And then, of course, you have your local geography, you have your local champions, you have your local administration, all that. You have some hurdles you have got to overcome, and these are highly local often.
You made an interesting statement earlier. You said that your hospital is a low-volume stroke center. And an analogy comes to mind. In healthcare education, there's been a large study showing that for nurse education, you can actually replace some of the clinical placement time for nurse students with simulation and achieve the same competencies. And I'm my question to you is, do you think that for a low volume center like yourself, you can compensate to a certain degree for that low volume with simulation?
Yes, I totally believe in that. For a couple of years, we wrote a review on simulation training in stroke together with Martin Kurz, and there we kind of line out our theory and our vision of healthcare quality improvement in stroke. And I think the main take-home messages from that paper and our vision are that simulation training should be a lifelong supplement for the physicians treating stroke and doing neurointervention with stroke patients, because you shouldn't learn on the patients, but you should learn and prepare on a simulator and then treat patients in real time, well prepared in treating them. And definitely this is more important for low volume centers not having the volume. I think high volume centers treating patients all the time, they have it in kinds of the reflexes in treating that. They have a lot of patience and practice, so they might not use simulation training as often as low volume centers. But I think centers as we should have simulation set up in their educational curriculum instead of patient treatments once a week, twice a week, just to keep up.
Interesting. Now, I'm sort of coming towards an end here, but I wanted to loop back to where you started, because you gave some very high numbers on the global burden of this disease. And I'm sort of tempting to ask you, and not to put you on the spot, but what is realistic in terms of influencing these numbers? I mean, we probably cannot influence right off the bat the 12 million that gets a stroke annually on a global scale. But what can we hope for?
I think the podcast title has the vision you you point to. I think it's really stunning that I'm working in a high-income country like Norway that has really good healthcare system, and people come to the hospital in a timely manner and they get good treatment. And by quality improvement in a local hospital in this setting, we can achieve effects on mortality and morbidity. And so you look in Africa and other low-income countries, low-middle-income countries that lack the resources we have, that lack the system. And if we implement the state-of-art training and can implement quality improvement program in stroke with these large effects of in mortality and morbidity, the effects are huge. In Africa, it's I think 80% of the stroke survivors die.
Oh boy.
It's huge number. The mortality is just incredible high. And that's partially because of the system. They don't have access to the system, but as well because of the system is not trained to treat the diseases. So it would be fantastic having the opportunity to contribute to this work in these countries.
And that really leaves us on a high note, I think. And what we need to get out of this episode and bring it with us, I think, is the ambition and the vision for bringing the best possible treatment, supplemented by training, like you talked about, to all people around the world. And that could have a tremendous effect. Thank you so much, Martin, for joining this talk on such an important topic, and good luck with your continued work.
Thank you so much, and thank you for having me.
You have been listening to a 1 Million Lives podcast by Laerdal. You can find all our podcasts and access any bonus material on laerdal.com/podcast. The views, information, or opinions expressed are those of the guests and do not necessarily represent those of the institution they are affiliated with or of Laerdal Medical. If you have any suggestions for guests or topics we should cover, please send us a message on laerdal.com/podcast. We look forward to hearing from you.
Until the next time, goodbye from the Laerdal podcast team.